So I get to my first school straight out of practice. Man, I'm just like you. I'm straight out of patient care. And I know what they have to do to meet the standard. This is what you got to know. And I got to tell you, I had a lot of very angry complaints. This is unfair. This is the wrong stuff. Don't want to hear it. But the thing about the Caribbeans is it's a trimester system. So those kids probably 9 months later were writing step 1. And they all talked back to their friends saying, doesn't matter if you like him, his stuff was the exam. And I went from being the jerk to being the star, literally in a 4-week period.
That's funny.
So remember, the students talk a lot. And as you build the culture stating this patient-centered really helps and works, you're not going to go through the flaming rebellion of all these self-appointed experts, because you only have to look at the results you're getting in student performance to say, this really works.
Absolutely.
If you're ready to give up memorizing and you're coming over to think like a doctor, hit subscribe. Okay, well, this is good morning to our audience. It is my deep pleasure to introduce a very close professional friend, Dr. Nancy Selfridge. And what is so wonderful about Nancy is that we met as teachers in the Caribbean, and we've kind of evolved together as teachers. And now we're really actively using this patient-centered approach you hear me going on about all the time. And so we're going to come and talk about Nancy's experience from her vast clinical practice to being a teacher, and now recentering on patient-centered critical learning differential diagnosis. So welcome, Nancy. How are things in the Bahamas?
Very nice today. We keep our eye on the weather.
Always in this season, right?
Absolutely.
I thought we could talk about how you wanted to go to medicine, how you got in, and then eventually segue into, you practiced for decades in Wisconsin.
Mm-hmm.
So why don't you sort of introduce yourself and sort of at a medical student interest level, talk with that in mind.
How did I decide to get into medicine? I was a good student for a long time, and science was fun. And I knew I wanted to do some sort of applied science. My father was a meteorologist. He thought that I would go into mathematics or physics or something like that. And I decided on medicine. And I can't actually tell you, what or why. I just made a decision to do it. And then fell in love in the process. I went to Southern Illinois University School of Medicine and also did my family medicine residency program there.
Now, how did you pick that school?
I had to pay for medical school on my own, and I was a resident of the state of Illinois, so I got some reprieve on the tuition.
Yeah, weren't we all broke?
Exactly, right? So it strongly influenced my decision because I knew.
Oh, me too, right? Yeah, that's why I stayed in state.
Yeah, absolutely.
Did you enjoy medical school, or is that just the hindsight of an old person forgetting the bad and remembering the good?
It probably is a little bit of the latter, hindsight. I obviously remember really high points, but I also remember getting kind of depressed in medical school too because of the volume. Southern had a 3-year, 36-month straight program, no breaks.
Wow.
Yeah, and I had done my undergrad in 3 years as well, so I was really on a fast train.
Now that you look back on it, do you think that was the right thing, or should you have done 8 or 9 months, take a break 8 or 9 months?
I'm actually kind of glad that it went that fast, but in hindsight, if I knew what I was getting into, I might not have picked it. On the other hand, the school was doing some innovative stuff. Yeah, they put us into study groups according to our Myers-Briggs personality inventory.
No way.
No, I'm not kidding. And I learned tons from my study partners because they thought very differently than I did.
Expand on that. What does that mean?
I had a tendency to be a really big picture person. Intuitive feeling is sort of my Myers-Briggs. We had one guy who was destined to be a surgeon. Another one of my study mates actually was a complete rational. So everything, had to make perfect sense, no gaps, you know what I'm saying? And it influenced the way I thought.
Now, did you have faculty come in and tutor or proctor you during your small group studies? What was your interaction with faculty in that setting?
No, our class wasn't very big anyway. I think we had a total of 63 students in the class. But you remember this. Remember the microscope work that we did in histology and stuff? That's where we'd had some small group supervision. But I never actually had small group clinical focus until clerkship. right?
And that really interests me because everyone is trying to flip the classroom.
Yeah,
And in my increasing experience with it, I think it's got the flaw that I don't think students can close the last 20% on their own. I think they need someone to come in after their group interactions and say, let's talk about what you thought you learned.
exactly, exactly.
So I'm a big fan of it, but
I noticed the exact same thing. And so even though we have a flipped classroom where I'm working now, the first part of the session is always let's check in on your knowledge, right?
right?
Absolutely. And I have to be prepared to do a sort of a mini tutorial or mini lecture.
No, that's my experience.
Yeah, yeah, absolutely.
I remember med school as miserable. I never understood why it had to be miserable. And it really harmed my curiosity and joy, which I had a lot. Like you, I was, it wasn't a hard thing for me to do. But boy, they sure took the fun out of it in my mind. So we'll come back later in the conversation and talk about how do we preserve cheerfulness and curiosity while we're trying to crush them with a bunch of stuff. Let's come back to that.
All right.
You graduate med school, and in your day, did you do internships or straight to residency?
Well, the residency included that sort of general first year, which was like an internship. They didn't call it that, though. It was your first year of residency.
So how did you pick family practice?
Oh, well, I initially wanted to go into women's medicine, OBGYN.
Yeah.
And I actually had interviewed in a number of programs. And I remember, I think it was St. Louis University was sort of kind of pinging me and where are you going to rank us, et cetera. And I woke up in the middle of the night in a cold sweat and had to accept the fact that I didn't want to give up peds and men.
Really? Now that you look back on that, were you right?
Yeah, I think so. I went to the residency director for the family medicine program in Springfield, and I said, I don't know what to do now. We're done with the interview cycle, and
I've changed my mind.
should I just go ahead and do a first year and then see, try to apply in family medicine? He said, we were wondering when you would come to your senses, and we'll give you a position in our program outside the match.
Yes. Well, I'm sure you were a prize to get. I'm sure they really did want you.
That would imply that they did. I don't know why, but anyway, it worked out. It was great.
False modesty is not really attractive, Nancy. All the rest of us know why they took you. Okay, so that was a good fit. You finished your residency. How did you decide where to go and what to do?
I happened to marry one of my co-residents, actually was in my medical school. He was actually in my study group.
Now, did you always know that you were attracted, or was it one of those sneak up and drop the bucket on your head?
No, we started dating pretty early.
I've always thought that two doctors coming through that way must be at a complexity to an already impossible institution. So I was obviously a single young male, and I'd look at all these married people. I go, how do you do that? I could never understand how that could work. So yes, I'm sure some of our students must think a lot about that, how hard it is to do this with a spouse.
And it's hard. And I would say, I was way underformed in terms of relationship.
Well, aren't we all?
Yeah, absolutely.
And that's sort of the definition of med school, isn't it? We're all sort of so committed to what we do, we don't develop experience elsewhere.
Absolutely.
Right? And then you add in the loneliness and the fact that we have the weird vocabulary that no one else understands, so we're always weird in any group.
Absolutely.
Tough group to socialize with and marry.
Absolutely.
Okay, so how did you decide where to practice?
I pretty much left it to Mark.
Your husband?
Yeah, absolutely. He found a place in Wisconsin, a small practice. We knew that we wanted to do small town practice. We didn't want to work in a big city or medical sort of setting. So we found Sun Prairie, Wisconsin, and the rest is history.
So tell us about that. What did you think? What was it like? Was it fun? Did you enjoy it?
I enjoyed it tremendously, but it was a different time, so I don't know what it would be like now. Remember, no electronic medical record. We were able to do everything from soup to nuts in our own office.
Did you deliver?
I delivered until I had my own kids.
Did you assist at surgery?
I assisted at surgery till I had my own kids. Yeah, absolutely.
Did you set bones?
Yes, absolutely.
Okay, so it was a legit family practice. This was no.
Reduced fractures, lacerations, vasectomies, colposcopies.
I've always thought the big break point of family practice was when they stopped doing procedures.
Yeah.
And then I sort of think they became, and I don't mean this too unkindly, I think they sort of became namby-pambies.
I would kind of agree.
Right? I mean, one of my very best friends in med school did bush medicine in, wild British Columbia.
Mhm.
And I always thought, he was a better doctor than me. I mean, I don't know that I would have been brave enough to do that. I mean, he was it, and he did it right or it didn't get done. And I always thought that's family medicine, not this sort of worried, well, and are your vaccinations, and we're going to talk about colonoscopy screening. I got to admit, I think I would find that hard to do. The wilds of medicine where, you're sort of taking a pen and using it as a stent. I mean,
Yes.
that's the real deal. So yeah, so you were actually a proceduralist family doctor.
Yeah, we did a lot of procedures, absolutely. And there was the usual ambulatory care too, but it was a different time. We didn't have quite the burden of chronic disease that we've got now.
Well, right, isn't that true?
Did a ton of peds,
But real peds.
real peds.
Sick kids with crashing O2s and spiking fevers and seizures and real peds.
Absolutely. And I liked psychosocial medicine as well. I like to help people make changes.
Okay, so you're a real family practice doc, procedures, serious illness, first assist at the scrubs. You do this for what, 25, 30 years?
Almost 30 years. Yeah, it was just shy of 30 years. Yeah.
So what happened?
I actually got tired of living in Wisconsin. I had gone through a divorce several years earlier, had started to work for other entities in Madison, Wisconsin. I just remember the day I made a decision to make a change. It had snowed heavily while I was seeing patients at work. Then I had to leave work. It took an hour and a half for about a 15-minute drive. And then when I got home, I had to clear the driveway.
So it was geography that broke you?
Well, I hate to say this, but yes, I wanted to work someplace else. But it's complicated. You've got to look for another practice if you want to do that. I had found a niche that I wasn't certain that I was going to be able to find someplace else. You know what I'm saying?
I do. How much of it was working for corporate medicine?
I was kind of tired of that, but I found kind of a mental workaround. In other words, I just stayed focused on the patients.
Well, right. You can always have that choice.
Yes, absolutely. And that's really how I was getting by day to day.
Okay, so you decided you've had enough, whether corporate, and you're pretty beat up from patient care, let's face it. You throw in life, you just get worn down. My friend in wild British Columbia, he just said, I just couldn't do it anymore. I was just done.
Yes, you get tired.
You do get tired,
Yeah.
and when you're in pathology like I was, we live with the false negative diagnosis.
Yeah,
You guys get crushed by the paperwork. We get crushed by the malpractice. And you're always living under Damocles' sword.
Yeah.
Right? And, people don't understand, but a big part of what pathology became in my career was surgical pathology,
Mhm.
which is intraoperative. And, it has a baked in the pie 3% error rate.
Oh, wow.
So I was doing 400 frozen sections a year, which meant I had an error every month.
Yeah.
And it just eventually saps your courage. And you guys get sapped of emotional and personal energy from these needy psychosocial patients.
Mm-hmm.
And all of us, somewhere around 30, 35 years, we all start to be depleted.
Yeah.
Okay, so you're depleted. You're going to pull the plug. How did you decide what to do next?
Well, this is bizarre because, I had another partner who Aon.
Yep.
And he was saying, oh, well, are there opportunities in the Caribbean? And I said, well, I know that there happen to be a lot of medical schools in the Caribbean. Maybe I could teach. I like having students in office. I like interfacing with them. My kids think that I'm the quintessential teacher because I taught everybody in every young girl in our small town about their first periods in detail,
No, my wife said I couldn't pass 2 kids kicking a ball. I wouldn't stop and teach them how to kick it better.
Right. Exactly.
I didn't realize that's what makes a teacher. So of course they were all right.
Sure. And so I think I drafted a letter of interest and sent it out. And within a week, I got a call back. I didn't actually even look for a position to apply for.
No, you didn't realize how desperate they are.
No.
You ended up, which island did you start on?
Dominica.
Okay, so you're on this tiny little island, right?
Tiny little island, yeah.
And you had to drive the hump,
I did.
right? I mean, I've taught there, right, a number of times. And you land at this teeny little airport, and then you drive the hump where everyone gets car sick.
Yep.
Okay, and now you're on this tiny little island, tiny little part of the island, and you're living in this community, basically on a beach with 2 stores.
Exactly.
Go ahead, tell us your story. How did that go?
Well, it was interesting. I was raised as a military brat, so I feel I don't get bothered by those things. I lived in a little thatched roof house for part of my sojourn in Belgium. So
What about the insularity and genuine strength of that tiny medical community?
that was amazing, and especially the students, the resilience that they demonstrated and their commitment, being there, being away from family, and really sort of digging in and not making any excuses. It was really inspiring for me.
Isn't it?
Yeah,
And what I couldn't get over, because I was on a small, not as small as yours, but smallish, was, you never separated work from play. I mean, you'd be in the grocery store and you'd be talking to your students about meningitis.
absolutely.
You lived and breathed medicine, right?
Absolutely.
It was a lovely community you were in. I taught there a number of times, and I was always impressed at just how nice the teachers were and how good the students were. I thought it was quite singular.
Well, I felt the same way. It was good.
So tell us now about going from practice to teaching.
Well, it was interesting because, when you go from practice to teaching, you really are struck with how many heuristics you use.
Explain that word.
Shortcuts, essentially, or these mental sort of constructs that serve as shortcuts to help you do your work. And I had to pause and ask myself all the time, why do I think this way? What do I think and why do I think it? And that was an important step for teaching students.
My take is when you come out of practice, you just don't realize what a first-year medical student doesn't know.
That's absolutely true.
Things you take completely for granted are complete foreign language to them.
Yes.
And I think that maybe going on 12, 14 years later, I still don't think I found the bottom to that.
I completely agree with you. Now, something that's really interesting to me, and it struck me early on in teaching, is I had done sort of as a side hobby some mindfulness and meditation training and actually helped to teach that. And one of the things that always came up was the beginner's mind.
Yes. Tell me about this.
And well, I just had this sort of gestalt in my head, this sort of construct of the beginner's mind, and that really helped me sort of anchor in to constantly be thinking about students and what they do and do not know.
So my first experience, I went to a classic school, and they basically asked me to teach some chapters of Robbins, which made eminent sense to me as a pathologist.
Sure.
But as you point out, they were smaller classes then, and we knew our students, and I would write my exam. Having taught it, I would write my exam, and then I would know my students how they did on it.
Sure.
And I just realized this is the stupidest thing I've ever done. They literally didn't know what I was talking about. And at the end of my first semester, I took Robbins and said, well, that's a really bad idea. And that started me on my journey of saying, well, what's the right idea?
Exactly.
And, you're going to pick me up in my journey a little later on. But basically, I always tell people, if you like this, it's just because of all my series of failures.
I get it completely. Trust me.
Right? You think, well, this is brilliant. And then you go, what did they learn? You went, well, not that. And of course, Robbins is written for a first-year pathology resident.
Right.
I can't think of anything more unsuitable for a first-year medical student.
Agreed.
So you and I talk about this a lot, right? Where do we start?
Yeah, exactly.
Okay, so you've started coming out of practice. You're miles over their heads. You're getting taught all your lessons in failure. Yep. Well, that was brilliant and didn't work at all.
Exactly.
How long were you doing that before you had a sense of, at least I have some sense of how to approach a beginning medical student?
I was in that position, what, 10 years at least?
No, you were on island 10 years?
Yeah.
Well, you must have known everything. And you're mostly teaching clinical skills, right? Have you started teaching didactic?
I started teaching clinical skills, but then with attrition of faculty, I moved into teaching didactic. And I think that, one of the things that happened is one of our faculty was a cardiologist left, and we needed somebody to teach ECG and sort of.
Of course. There's no one else. It's you.
And I realized that the discipline-based curriculum just wasn't working very well. Students were doing a first pass through cardio-physio, but then when we would get them for the clinical semesters, and I'm not talking clerkship, it's still pre-clerkship, they had forgotten everything that they'd learned and couldn't pull it forward to make sense of pathophys. You know what I'm saying?
Oh, yes, I do know what you're saying, madam. So years of watching this, what did you conclude?
I concluded that we had to do stuff differently. And one of the reasons I'm not with that particular organization anymore is because of how hard it was to talk to my basic science colleagues about true integration.
It's a doozer, isn't it?
It's a doozer.
Okay, so you're there 10 years. You're really enjoying it.
Yep.
You're in this. I mean, you know how I always viewed your community there? I always viewed it as Shangri-La.
It is.
You came over the pass, and there was this little poetic, tight community in which malefactors were just asked to go back over the pass.
Yes.
Okay, so then the hurricane.
Then the hurricane. Cat 5 hurricane, survived it, crouched in the little bathroom with my cat. I remember turning to my partner and saying, "What's that noise?" And he says, "It's trees." And I'm like, "What are they doing?" He said, "They're breaking." But we didn't have any little trees anywhere. They were all, huge trunks. And when I went out the next morning, of course, everything was flattened. Do you remember how rich and lush everything was along
perfectly.
that river that was right next to the school?
I loved that river.
Flat. Yeah.
I never understood, why didn't they rebuild? Why did they move? I never ever heard a good explanation for that.
I never heard a good explanation either.
So, and I think, Nancy, there's a truth there. We're looking at the effects of capital-run businesses instead of family, personal-run businesses.
Yes, absolutely.
I think the VCs that bought you out basically thought that was a hard place to do, and they didn't have good control.
I agree with that.
And they're right, actually.
Yes.
Okay, then comes the move.
The move put us on another Caribbean island, more developed, but we went from I was walking to work every day, which was lovely. It took about 12 and a half minutes. To having to commute 45 minutes one way.
Unpleasant, by the way.
Unpleasant.
It's a nasty drive.
It's a nasty drive. Yeah, absolutely.
But the one good thing that came out of that was that that's where you and I met.
Exactly.
So I have to tell the students, and each of us get to tell their own side of the story. I got to tell you. So I've got this pretty high VP in the system, wants me to come and show the island what patient-centered learning looks like. And I've been doing it a lot. So I knew perfectly well the act of hostility I was going to face, but I liked my sponsor a lot, and what the heck, it's really fun to do. And in that, I think they kind of shoved the interview with me down your throat, because I know you were on my schedule. And the next thing, I'm walking into this very weathered, serious old woman who's looking at me like, "Okay, you got 5 minutes to make your pitch, but I'm busy." So I really enjoyed the first look you gave me. And it took me about 10 seconds to realize, and you can jump in with your own side of the story. It took me 10 seconds to realize medicine is a balance, right? Between the socio-emotive side of medicine and the technopathology molecular side of medicine. And obviously you have to have both, right? There's no such thing as one or the other. We sort of choose where we are in the spectrum.
Exactly.
And I remember it took me 2 seconds to figure out you were high on the socio-emotive side.
That's funny.
right? And obviously I'm the technopathology all the way. I make no apologies for that. So I was looking at you going, oh, this poor lady's had me foist on her. And she's going to think I'm sort of one of these hard, hey, spare me from that ushy-gushy patient care stuff. That's what I read on your face. And so I thought, well, I guess a point has to be made. And all I would talk about is how the hypothalamus runs everything.
Perfect.
And you should have seen your face. It was like you just didn't see it coming. It was like a genuinely happy meeting. Do you remember it at all?
No.
Yeah, well, you were tired and busy, right?
Absolutely. I do remember coming and watching you teach, though.
Oh, tell us about that.
And I can't remember exactly what you were teaching, but I remember sitting there and thinking, this is the Rosetta Stone.
This is truth.
I have discovered the Rosetta Stone, right? This is what I was looking for. This is the way that we can pull everything together.
Well, that was certainly my intent.
No, I recognize that. It's just that, this is what you've learned to do over time.
Pure failure, right?
Yeah, absolutely.
Someone was asking me the other day, how do you come up with how you think about this? Because it's so different from everyone else. And, there are two thoughts that I think you have to do. First of all is you have to recognize that you failed teaching the original way.
Sure.
The idea is, but here it is in my slide. They should know it. Mm. No, you are right. It was in your slide, but they didn't know it. So you failed as a teacher.
Yes.
And once you take that the student is right, I think what you'll find when you come out of decades of practice like us, what you say is, okay, well, how do I think of it?
Right.
And that's basically, if you ask, where does it come up with? I just sort of go to, how do I think of it in my mind's eye? Everything you see basically is that.
Absolutely.
The second thing that I think people have a lot of trouble understanding is, I'm not special. I'm not unique in thinking this. This is how everyone thinks of it. They just haven't written it down, or they know it so intuitively, as you would say, heuristically. It's not until I speak it that they go, yeah, that guy.
Yes.
That sounds about right. Let's do that.
Well, and that's what struck me, is that every step of this thinking was so thoughtfully laid out. I was able to just, oh yeah.
That is my heuristic.
Yes, that is it. That is it. But you don't know that until you labor over it a bit, right?
Yes. Oh, yes. No, that's right. You have to go teach it.
Yes.
If you don't go teach it in front of a group of students, you're just a theoretician, and we got plenty of those.
Absolutely.
Okay, so my experience now was two big things happened to me on the island. First of all, I met Eric. He was the one person that not only believed it, but started to do it.
He did. I watched.
And every time I'd come, right, because I must have been there 8 times or more, every time I'd come, he would grab me and make me sit down with him for a half day and teach him a new system.
That's so cool.
And then he would come back and tell me his experience using it.
Mm-hmm.
So he became the first person that was a true believer, but not you.
No, I know.
You know why? You were too busy.
Yeah, exactly.
Yeah, you were too busy. When we talk about systems, here's what we're not talking about. Who teaches the teachers?
Exactly.
Oh, you can't imagine how much I enjoyed watching your frustration. I just knew you knew it was right. You just, where am I going to fit this in? I'm working 16 hours a day.
Absolutely.
Okay, so Eric becomes the first believer. And the second thing is, of course, the PhDs dropped me from the program. As I like to phrase it, I got voted off the island.
Yeah, that's hilarious and predictable.
But remember, we picked them up again when they were coming for their clerkship prep.
Yes.
And that's where I just gave the program to Eric, and he mastered it.
Yeah.
You get taught this, you repeat it, teaching it 4 or 5 times, and it owns you.
Yep.
So I'm sure that was, again, doubly frustrating for you, right? Because why the heck is he the guy that gets to get good at this? And here I'm doing administration work.
Exactly.
Okay, so then you decide you're going to make a move again.
Got an opportunity to start a new medical school with one of the colleagues from the old place, who is a fantastic administrator, which I knew intuitively. If she listens to this, she'll probably laugh. That it meant that there would be less of this, what my father used to call nitnoy, that I would have to do, right?
Okay, so now you get to design it the way you want. Wasn't quite as easy as you thought, huh?
No, it wasn't at all. No, because everybody wants you to document that you start with the USMLE content outline. And, starting with a content outline is not the way to think about organization.
You mean it's not patient-centered?
It's not patient-centered. But I think I can't remember at what point I did get access to your book, but it's had a huge influence on how we organize our sessions with students.
Talk about that.
I think that the majority of our sessions are patient-centered. We have students use resources, including your book, to prepare. We do problem solving in class, which includes talking through cases, drawing pictures, labeling. We are really deliberate about repetition. So, for example, students learn about foundations of neoplasia in their first semester, but we hit the same foundational concepts again and again every time we talk about cancer in an organ system or neoplasia in an organ system.
When you do use the pathophys book,
Mhm.
aren't you surprised how ordinary and obvious it is?
That's challenging for me because I get what you're saying in terms of the logic of everything and the bits and the bytes of information and the way, but it's the whole mass of it that is actually an opus. You know what I'm saying?
Basically, what I do is I take every expert
Yeah,
and ask her, how do you think about?
yeah.
And then I just kind of document it with my large experience of first and second year medical students,
It's cool.
right? So you've been using that, right?
Yes, absolutely.
Right. And it works, doesn't it?
Yeah, absolutely.
Have you been surprised how well it works for the teacher?
We don't have all of our teachers doing it, but yes, absolutely.
This is what I've loved so much about watching you, is that you obviously recruited Eric to this school. So A, you had this great quality person, but B, you had the daily reminder that you weren't quite as good.
Absolutely. Absolutely.
So, but over the years, you've just been teaching and absorbing it, right?
Hmm.
How does it work for the teacher to say, this is the level of a medical student and the way it should be taught? How does it work? If you're really busy, you don't have a lot of time to prep, if you just grab it and use it, how does it work?
I think it works really well.
Yeah.
Obviously. I mean, I prep significantly for sessions, Philip, you know.
We haven't repeated it 10 times.
Right, I haven't repeated it 10 times, but one of the cool things is there are so many images that work so well. You know, your chronic disease graph,
Oh, isn't that the best? I love that graph.
right?
Ask how I got that graph, which once you see it is the most obvious thing in the world, right? You know where I got it? I would be talking about a disease in its early days, and the patients would give me symptoms. And I'd go, why would you think it has symptoms? Like, go ask your students about, pick one, ascending aortic dissection.
Mhm.
And you go, okay, so it's a 35-year-old Marfan's. What symptoms do they have? And they'll always tell you dissecting chest pain.
Yes,
No, they don't have any pain.
right.
You don't have pain until it dissects.
Exactly.
And you fail like that a gazillion times and you realize they don't have chronic progressive disease in their head.
Exactly.
Go teach staging of renal failure. How many people can do stage 4?
Exactly.
Yeah, so you like that picture, hey?
I do.
Yeah.
Because it comes back again and again, so that's
Oh.
something I can quickly draw out for students to remind them of that first part of the disease where we're gradually losing function, right?
But it's compensated.
Yes, exactly.
So I'm teaching in a school now that is a very classic school, normal first year, pathology second year.
Mhm.
And you know what I have to keep reminding and reteaching? The difference between homeostasis and adaptation.
Interesting.
It hasn't been clinically put into their head with a chronic progressive disease. First it's physiology, then it's adaptation, and then it gets symptoms during periods of decompensation, and then failure's always symptoms.
Absolutely.
I think I'm going to have to do it 20 times before they recognize homeostasis and adaptation are different.
Interesting.
Well, you go try it today. Tell me if I'm not right.
I will. Wednesday, teaching obstructive restrictive lung disease. So we'll go in. Yeah, perfect. Right?
Perfect.
Perfect.
You know, all you have to do is stage it.
Yes.
Take the gold staging system and go try it.
Okay.
It works really well for that. The trouble with lung is it doesn't have a lot of adaptation.
Right.
That's why we start with heart, right?
Yes.
I think the only good adaptation you're going to get for lung is when you talk about why is chronic bronchitis? Where does that mucus come from?
Yeah.
Right? Go ask that.
Okay.
And then you can ask about, so why do we talk about the Reed index?
Yes, exactly.
Because it's just a measure of hyperplasia.
Absolutely.
So go try that out and tell me if you don't laugh about how they go, oh, wow, that actually really works great.
I used some pictures from your book.
Oh, good. Let me know how they work.
Yeah, absolutely.
Okay, so tell me about your magical design of the 5th semester. I mean, that is your invention, and it is friggin' magical.
Quite honestly, I'm not going to take full credit for it. You know that.
False modesty is not terribly attractive in people our age, Nancy, but go ahead.
I'm not. We knew from the beginning that 5th semester, the plan was it was going to be a review. How it was going to be laid out, actually, I took a lot of input from Eric, and I was up. You know that I was inspired by you as well.
Oh, yeah, for sure. I've always thought of it us as the 3 of us.
Absolutely. But, the fact that we have students do patient-centered topical reviews, and they work in triads, and they use your book, and they have to create a presentation for the class.
Oh, you've missed the beginning, doctor. That's not how it started. Because remember, I came out to watch because Eric did it first, right? And I was spellbound because this is the first time people had done what I really thought was important.
Sure.
No, Eric and I presented the patient.
Sure.
And then I went away so he could do what he thought was better. And then he had the students do it wasn't until they got me off the island that he got them to present the patients.
Well, some of that, too, is the fact that, as we've sort of refined our faculty, we're doing more of that patient-centered teaching in the classroom in the first 4 semesters.
So it's not as shocking as when we first dumped it on them.
Not as shocking. It's not as shocking. Anybody who really hasn't wanted to buy into it doesn't stay with us for very long, right?
Any teacher.
Any teacher, yeah.
Okay, so tell me about the student response to it as you documented. What have you been doing now? 3 years, or are you into your 4th year now?
We're into our 4th year.
Tell us about the student acceptance of it.
Well, it looks profoundly good to me, but I don't think they know from anything else.
Oh, so you see, I can tell you, I was there for the first year. You were just watching Eric and me do it.
Yeah.
The first year was shock. Because you would ask a perfectly fair question. Okay, shortness of breath. What organs are we in? And they would give you that look of, I've been here for 2 years and you've asked this perfectly fair question and I've got nothing.
Yeah, but now they're good at it. Because we've asked it so many times.
Right. But
Yeah.
that first semester was shocking. And, we were asking them and looking at them. So there's no weaseling and hiding behind multiple choice questions here.
Exactly.
So that was intensely gratifying. And, one of the lessons I will remind you, because it's important for the students to hear this. The class, it was very few. We had like 16 kids. And they kind of broke into the 8 that got it and were passing their tests, and the 8 that didn't and weren't. And I don't know if you remember, but you came in with your hard, no fooling hand and said, you 8 are going to spend your afternoons with Dr. Tisdall.
Yeah.
And so they had to show up, and I was looking right at them saying, draw me how you think of the heart.
Yeah.
And even though I drew it for them, one student walked up with the chalk and looked at me and said, I don't know where to put my first line. So if you think it's easy to do this, trust me, it's not. So I literally drew each circle with him.
Yes.
And then I made him do it twice, boring for everyone. I don't care. Watch this. Okay. 3 weeks later, I saw him condescendingly lecture someone on how to think of the heart.
How gratifying.
Oh, and how did they all end up doing? Remember, they did that for a whole semester. And how did they all end up doing?
They did well, I think.
Didn't they?
Yeah.
This really works. But it's not easy, is it?
No.
So then Eric flips the classroom.
Yes.
So my first lesson for all you students is, if you've never done it, it's shocking. And if you think you're just going to walk up to a piece of paper and draw, well, give me a call, give Nancy a call. We'll walk you through the first.
Absolutely. Absolutely.
So then I leave so Eric can do what he wants, and he flips the classroom. Did you go watch those first few?
Yes.
Yeah, it was pretty painful.
But this particular group that we've got this semester are extraordinarily good.
Oh, but you're the second try. They've all got a culture to build on.
Yeah, exactly. So at first it was really gruesome. It was hard.
It was gruesome. I was there, and I mean, there were student rebellions that we were stamping out.
Absolutely.
This is stupid. I don't want to do it. I feel self-conscious. Don't want to hear it. We're not going to sit here and just lecture you. You've got to own it.
Yes.
So that was the first semester. We actually had some really entertainingly ugly moments.
Yes.
But so here's what you have to bear in mind when you talk about how much smoother it is now.
Mm-hmm.
So I get to my first school straight out of practice. Man, I'm just like you. I'm straight out of patient care. And I know what they have to do to meet the standard. So, this is what you got to know. And I got to tell you, I had a lot of very angry complaints. This is unfair. This is the wrong stuff. Don't want to hear it. But, the thing about the Caribbeans is it's a trimester system.
Sure.
So those kids, probably 9 months later, were writing step 1.
Interesting.
And they all talked back to their friends saying, doesn't matter if you like him. His stuff was the exam.
That's handy.
And I went from being the jerk to being the star, literally in a 4-week period.
That's funny.
So remember, the students talk a lot.
Yes.
And as you build the culture stating this patient-centered really helps and works, you're not going to go through the flaming rebellion of all these self-appointed experts. Because you only have to look at the results you're getting in student performance to say, this really works.
Absolutely.
So now it's a happy crew coming through.
Yes, finally.
Okay, but then the sad news for you, but good news. Eric's leaving.
Absolutely.
Tell us what's going to happen.
I'm taking over 5th semester.
Feeling a little nervous, are we?
I've taught in almost all the organ systems except for renal. So what I've done is I have just dug deep into your book, and I'm practicing. Yeah.
Yeah, and I'm teasing you, but I want the students to understand.
Yeah.
I was no different. All of us start here, right?
Exactly.
We're all students. And the students, if you're looking for an expert, then you're in the wrong place with anyone.
Exactly.
Right? You should look how your teacher learned and think a lot about maybe you should do that too.
Yes.
So, I've been quite open in saying to you, you should share with your students that they can watch you learn and get better.
Yeah, I think that's it's going to have to be that way.
Well, no, I faked. I never did that. I was way too old school, man. I had it all. Anything I couldn't remember, I wrote out the page so I could read it to them. And I faked my way through that for a long time. But I wouldn't do that now. I would actually open up and watch them watch me learn.
Well, and it's fun. I mean, I had a very interesting session with a student here, just sitting down and working some UWorld questions. They have the UWorld question bank.
Don't we all?
I don't know. I don't know all the answers to those questions. Right.
I miss them regularly.
But we sat down and just picked a bunch of random questions, and I was talking through them the way I would reason through the question. And we were getting about 90% right. And she said, "You talk to yourself while you do these questions?"
Yes.
I said, "Yeah, absolutely. I talk to myself through any patient problem, right?"
Yes.
There is an inner dialogue going on. I'm sorting,
Yes.
I'm thinking, I'm making an argument for or against, right? This is going, this had escaped her somehow through this entire process.
One of the tips I teach students is, after I've had a chance to walk through how clinical medicine works, and that is its own discussion, I always say to them, when you read the question, don't read it. Imagine I'm standing beside you in the ER.
Yes.
And saying to you, hey, listen, I've got this 18-year-old girl. She's had multiple sexual partners. She's coming in with low pelvic pain and a discharge. Why don't you go in and see her and come back and tell me what you want to do?
Yes.
Right? They're all conversations.
Yes.
Yes, I think it's hard for students who haven't met patients to understand they're all conversations.
Yes, they are.
When I write the STEM, I'm literally talking to you.
Exactly. Getting students to recognize that the item writers are essentially doing the exact same thing we do in clinical medicine all the time.
Or it's not a good question.
Or it's not a good question, exactly.
Okay, so I want to remind you of the third iteration. So if the first iteration is you use your political clout to
Uh-huh.
flip the fifth semester to patient-centered learning.
Mm-hmm.
And then Eric flips it to students presenting patient-centered learning.
Yes.
You gave me the chance to have a third one, which was I did the review patient-centered, but then I had the students each write a multiple choice question on that day's material.
Yes.
And boy, was that productive. You get to watch their minds.
Mm-hmm.
Because when you write an HPI or a question stem, you get to see if they understand the medical order of reasoning.
Yes.
And so this might be beyond the students, but I think you'll appreciate it. So you start with your chief complaint, right? Which automatically flips the differential in your mind.
Mm-hmm.
You know what the next sentence is, Nancy? It's tell me anything out of that differential that's pathophysiologic. So let's talk about that. If I say shortness of breath, heart, lung. If it's heart, it's congestive heart failure.
Yes.
Tell me two other pathophysiologic symptoms of heart failure. One would be paroxysmal nocturnal dyspnea.
Absolutely.
And the other might be edema if it got back to the right side.
Yes.
So because those are so clearly part of the picture,
Mm-hmm.
you have to include them positive or negative in the next sentence.
Yeah.
But after the pathophysiologic sentences, then you go to the prevalence sentences. So then you say smoker, hypertensive, diabetes. They're not in the pathophysiologic chain, you know,
Yes.
but they're in the prevalence of risk factors.
Yes.
And it wasn't until I watched the students write questions I realized how often they got that confused. Hypertension isn't pathophysiologic, it's a risk factor,
Yes.
right?
Yes.
But if you've got coronary artery disease and dizziness, yeah, well, now all of a sudden, that's all part of atherosclerosis.
Yes.
So one of the things, because I know you got a small group coming in, one of the things after you feel things have settled down,
Mm-hmm.
get the students to write some questions and watch their minds.
Yeah.
Because I watch your students over the 3 months, I could watch their minds clamp down and improve. It was thrilling.
Yeah. Yeah.
So that's I think that's going to be the last iteration of your magical fifth semester.
Well, and it fits with what I'm really trying to at least talk about with the students is get in the mind of the item writer. That's going to help you tremendously, right?
Can you do that without trying to write a question?
Yeah, I don't think you can. I
Yeah,
don't think
right.
you can. I think you have to labor with it. Yeah.
But the lesson I learned was it's not good enough to write it. You have to have a medical educator critique it,
Makes sense.
which is very labor intensive.
Yeah.
What's next in your life? So you've taught forever. You feel that you finally got to a group of medical educators with Eric and me and what we're all doing. Clearly, we are going forward with this.
Mhm.
What do you want to do next? Clearly, you love this and you're really good at it. So what's next for you?
I mean, you and I have talked about collaborating and trying to promote this more widely because it's just intrinsically good for making doctors.
So we've got our producer, Allie, here, right?
Yeah.
And one of the things we keep talking about is as we expose this to social media, we're going to create a community,
Yes.
right? So when you ask where I'm going with this, I've got two big projects going now. One is I'm working with a medical school to see if I can drop the book into the school and it's a nidus for crystallization.
Right.
That's really interesting to me. That's a multi-year project. But the other is, you know, with this social media exposure we're getting, can we form a community? How fun does that sound?
And it sounds great.
After that, can you stop teaching?
Well, I would miss it, obviously.
Immediately, right? Okay, so what would you say now to the students that come and listen to us from all over the world? Talk to them. I'm going to give you, here's your open mic, and you get to talk to medical students based on decades of practice and decades of teaching.
All right. So I would just say to students, if you're sitting in medical school and you're struggling seeing why what you're doing in the here and now has anything to do with taking care of patients, Dr. Tisdall and I have this sort of mantra. We say hashtag make me care. If you find yourself wanting to say that to your teachers on a regular basis, then I would say consider patient-centered care, learning this particular way of doing things. And it's very easy now with Dr. Tisdall's book. It makes it easy to follow and pick this up, and it will make a ton of sense of everything that you're learning. Not everything, but a good deal of what you're learning if you have a more traditional medical education program.
Tell me about how you think they should go about actually learning it. So here's the book. What do you think is the right approach in a life to do that?
The first thing to do is actually just read the book, but it'd be great to have a tutor or mentor. And that's what the community I would envision would be good for. So I don't know if you have any ideas how to make that scalable.
Oh, I assure you, there are lots of people in the world, and I live with some of them, who are very big on how we're going to do that with self-teaching and then monitoring by us. And
Yes.
that's a really active part. My worry is that right now it's just me.
Yes,
I'm already full-time at another school.
I know.
So the trick is, get other medical educators.
Yes.
And so you and I have talked about this. That sounds really attractive, doesn't it?
It sounds attractive. The challenge is, can we find people who are interested in learning how to do this?
Oh, you and I didn't even know we wanted to teach till
No.
we were in our, right?
It's true.
And so I think what we'll do is we'll make it easy for people that think they might.
Mm-hmm.
And here's all you have to do.
Yeah.
People don't understand. It takes me 10 hours to prepare for a new 1-hour lecture.
Mm-hmm.
If you have the book, you can just cut and paste it.
Yes.
That would have revolutionized. I would have spent much more time teaching and much less time in prep.
Yep, absolutely. Well, and you know that I can vouch for that because I've used your book extensively for teaching.
It really speeds it up, doesn't it?
Yeah, it does. It does.
Okay, tell me, the last thing I want to ask you about, tell me how much behavioral affects the learning experience for most students based on your vast number of students you've seen.
What do you mean behavioral?
Well, I think that when you're coming from a first-generation American, I think family obligations are a major distraction.
They are.
I've found myself explicitly teaching students, no, you come first, not your family. Just for this
Yeah.
period of med school, right?
Yeah.
People in relationships become
Yes.
so emotionally perturbed, they stop studying.
Yes, absolutely.
People away from their parents in these wild islands suddenly think the rules don't apply.
Absolutely.
So just talk a little bit about how we expect and behavior matters.
Actually, you end up having to accept the fact that you're almost going into monastery. And this doesn't mean, no sex or, no drinking or whatever.
Yes, it does, Nancy.
Now, there is time for partying, but what it means is that you have to have a singular focus. Where do young people anymore get an example of a singular focus? I was raised by a military father, and so that was part and parcel of daily life with him was singular focus. I wouldn't say that our upbringing was as hard as basic training, but close, right?
Yes.
And so this message constantly, just focus on what's in front of you, what you need to do, the task at hand. It was kind of built in to our upbringing. But I know it's hard for students now. They have social media.
Constant distraction.
Yeah, I think we found one of our students was spending 50 hours a week on social media.
It's very addictive.
You can't study the required amount of time if that's where your attention is. So it's like making a commitment.
So, this is how I teach it. Tell me how you like this. I teach this. Medicine is so demanding that you have to take breaks to recharge.
You do.
You don't get to play because you've earned it. You get to play because it's necessary for recharging to go back to medicine.
Absolutely.
And I think your phrase, it's a singular focus,
Yes.
is exactly right.
Yeah.
You aren't owed anything, but you do have to recharge.
Absolutely. And recharging makes sense. You know what? I said after I had my first child, I said early motherhood, the only thing that prepared me for it was my residency.
Always being sleepless, thankless.
Singular focus, right?
Yeah. Wow, how much fun has this been? Okay, so we're going to have to revisit with you
Okay.
after you've alone taken on the tiger of fifth semester,
That'll be fun.
and you're going to tell us what it's like
Okay.
to, to embrace the suck and change and be responsible for all of it. You're going to have to come back and tell us about what you've learned.
That'll be exciting. The students are going to watch me draw out an Ephron. Right?
Well, Nancy, thank you for all your time.
Absolutely.
Okay,
Thank
we'll
you.
talk again soon.
Yep. Take care.
Every week, I'm going to be putting out a new thought on how you can learn medicine through a patient-centered approach. Remember that everything is going to be basically my brain in a book. So this is our book. You're going to need it. It's all the ideas and the vocabulary that we use. And you're going to want a copy of that when you hear something in the discussions so that you can go and refresh and deepen your understanding of it. So if you want the book, remember to click the link in the description.